I'm one of the doctors working at Cambridge University Hospital, and I'll be explaining to you one of the questions that come in the MSRA and PLAB 1 exam, and it is one of the preoperative questions that is very common topic, which is preoperative diabetes control. So you have here, in my question, you have here a 60-year-old male patient presented to the hospital for his elective inguinal hernia repair. So elective inguinal hernia repair, you need to be very careful what you're reading. So this is a minor day surgery, right? This is a minor day surgery. So it happens just one day, patient goes sleep and then do the hernia and then get the patient out 2 hours, 3 hours, and then the patient can absolutely go home in the same day. So he's diabetic and he takes a medication called metformin, right? So he's basically, you're expecting that he's type 2 diabetes and he is taking an oral medication. So this patient is not on insulin, right? His blood glucose has been well controlled. Well controlled, that means his hemoglobin A1C is less than 59, right? And his surgery is listed in the morning, first thing in the morning. And he would like to know what to do with his medication before surgery. So we have here multiple options. So what are we gonna do? So you have a patient who is absolutely normal. He's a 60-year-old male patient, and he presented to you with for an elective inguinal hernia repair, and he's known to be diabetic, but his diabetes is really well controlled, and he's only an oral treatment, and his surgery is listed in the morning. So you have done all the good things. So what will be your management for his metformin? Would you give him half of the dose on the day of surgery, on the day before surgery? That's important. Or omit, which means you stop the metformin on the day before surgery, so 1 day before surgery, or half the dose of metformin on the day of surgery. So notice this is before surgery and this is day of surgery. Number 3, continue metformin as normal the day before surgery, or start the patient on VRIII, which is variable rate intravenous insulin infusion. So among all these options, so you're having a very normal patient who is just diabetic and is on oral control, and the surgery is very minor and it happens in 1 day. I don't see a reason why I can't continue the metformin on the same dose. So here it shows continue metformin as normal the day before surgery. And then the second day, the patient can continue metformin as well and have his surgery done. And then you can just skip 1 dose before surgery. And we're going to go into this into a bit more detail. So I'm going to read with you. So a patient who is an oral anti-diabetic, okay, so a patient who is an oral anti-diabetic, it should be taken as normal the day before surgery. So what happens on the day of surgery? And this is what we're going to discuss in here in detail, all right? So, continue metformin as normal the day before surgery, the correct answer. And patients with diabetes has increased risk of 2 things. Number 1, post-operative infection, and number 2, delayed wound healing due to poor glycemic control if omitted. It also, there is an increased risk of lactic acidosis if the metformin is continued. So there is a potential for hypoglycemia when taken concomitantly with other blood glucose lowering medicine and the continued during elbow mouth period. So here is going to mention to you if the other wrong answers and why they are wrong. I'm not really interested in this for now. So let's go into the preoperative surgery. So it's mentioned to you if you are an SHO working in, working somewhere in whatever surgical department it is, what would you do in a preoperative admission clinic? All right. So for any elective case, you need to see the patient in something preoperative assessment clinic, which we call it PAC. You can call it multiple things according to your hospital. So in this part, you need to get the patient to the pre-admission clinic to address all the medical issues that they have, to know, for example, are you diabetic? And if they are, what kind of diabetes they have? Is it type 1 or type 2? And whether it's oral or insulin controlled, and what would you do in this, and give the patient all the advice about that. Number 2, if the patient, for example, have a cardiac stent, and is he on some kind of anticoagulant medication, and do we need to stop this anticoagulant medication? Will it be just 1 day before surgery? Will it be 1 week before surgery? Will it be more than this? So this is a second question. So that's why a preoperative assessment clinic is very important. So you need to consider a pre-admission clinic for assessment. You need to do all the blood tests for the patient. And obviously I'll take a good history from the patient about their medical issues. I will take including the medication and social history, all the questions that you need to ask. You need to do a few bloods, and group and save, which is group and screen, which is basically cross-matching. You need to do 2 of those, 2 group and screen. All right. You need to do urine analysis, pregnancy test in a female patient, sickle cell test is not routinely done. You need to do ECG and a chest X-ray if the patient is more than 55 years old. Okay, so these are the things we need to check before any elective admission. However, there are some cases which is a bit different. There are some cases which you will ask for different tests. So like I mentioned, if the patient has been taking aspirin, for example, so you will need to get him a very good FBC and sometimes manual count to his platelets, right? And let's say if the patient has hemophilia, so probably we'll need to get him factor 8 before the surgery, right? And you will need to discuss with hematology. So you will need to address every other issue individually according to the patient. So you will need to do something called the risk factor for development of deep veins thrombosis should be assessed, and this depends on the patient mobility. The patient do they have cancer, and the patient age as well. There are a bunch of questions that you need to ask to the patient, and then you will make your assessment. And this tells you if the patient is at high risk of DVT or not, and whether or not they will need something called dalteparin or prophylactic low molecular weight heparin. It's either dalteparin or enoxaparin or anything of these medications. Okay, so the next question that your patient usually asks, am I nil by mouth, or when is the last time I could get something to eat or drink? So the ideal management of patients is they can eat and drink clear fluids until 2 hours from surgery. But the definition of clear fluids is different. What does it mean? Drinking clear fluids before the operation can help reduce headaches and nausea and vomiting afterwards. So clear fluids are basically, water is the best clear fluid, right? Water is the best clear fluid. Fruit juice, but doesn't have bits. So don't let them get the Tesco bits orange juice. And also the coffee and tea are considered as clear fluids, but it should not have any milk or ice solids in it. So basically, you can say to the patient, you can get water until 2 hours before surgery, and that's it. But food or non-clear fluid can happen until 6 hours before surgery. 6 hours before surgery. So this is, the patients are generally advised to fast from non-clear liquid for at least 6 hours before surgery. Okay, so diabetes management. The management of diabetes during surgery is an important and relatively common problem. There are, some guidance from the PNF, the NICE guidelines, and German British Diabetes Societies have produced guidelines. Many hospitals have their own protocols. So it depends where are you, and if you are in a certain hospital that would like to follow their own, their own guideline, that's fine. So there are 3 questions here, or maybe a bit more than that. So you need to ask, what is the duration of fasting that is required for this patient? Which type of diabetes does the patient have? what type of control of diabetes that the patient have. Has his diabetes been controlled recently or not? Is this a day surgery or a major surgery? Is this an emergency or an elective surgery? So basically it's loads of questions. But the main points here that you need to answer is required duration of fasting before surgery. Is it maybe 6 hours or is it just 2 hours or whatever? And also the timing of surgery. Is it a morning or afternoon surgery? Okay, does this matter? Yeah. If it's a morning surgery, the patient have enough time with you at hospital before you send them home. If it's an afternoon surgery, that means the patient will be fasted for a longer time. The cortisol level will be a bit high and causing them more hyperglycemia. What is the usual treatment of the patient? Is it an insulin control or an anti-diabetic drug control? And what is a pre-glycemic control, which is the hemoglobin A1C? And is there any other comorbidity that the patient has or not? So answering all these questions will guide you on what to do next for your patient. So for example, if you have a patient with just 2 hours of fasting and the timing of the surgery is in the morning, and his usual treatment is an anti-diabetic drug like metformin, and the pre-glycemic control is absolutely controlled, and he does not have any other comorbidities, so basically I will just continue with medication. We're just thinking logically, right? So the potential complication of poorly managed diabetes during surgery, this includes unwitnessed hypoglycemia, undetected hypoglycemia, there is increased risk of wound and respiratory infection, increased risk of postoperative achy eye, and increased length of hospital stay, which is the main thing that we're looking for. The main thing you're aiming for is to send the patient home as soon as you can, safely, right? So there is an increased risk of wound infection, increased risk of respiratory infection, and postoperative AKI is high, and also increase the risk of hospital stay. Let's skip this area and jump to our table, which is a pretty important table. So if you look at this table here, it's telling you which medication. So this is basically is telling you which medication are we giving, and here the day prior to the surgery, and there is the day of surgery. Okay, so the metformin the day before surgery. So this is an oral control. So you are expecting this is type 2 diabetes mellitus, and mostly it will be well controlled. The day before surgery, you continue as normal. The day of surgery, you need to, if taken once or twice a day, so here it's divided. If it's taken once or twice a day, you need to take as normal, okay? If it's taken once or twice, you take as normal. If it's taken TDS or 3 times a day, here when you need to omit the lunchtime dose, just omit one dose, which is the lunchtime dose. Okay, so metformin again. So let's revise the metformin again. So metformin, this is an oral anti-diabetic medication that is controlling type 2 diabetes in most of the cases. So if the patient is taking OD or BD, you need to continue as normal, okay, in the day of surgery, okay? And if it's TDS, you need to omit the midday dose or the lunchtime dose, all right? So this is for metformin. Sulfonylurea, again, it's an oral medication. It's an oral medication, mostly for type 2 diabetes mellitus. You take as normal day before surgery. And again, if it's taken once daily in the morning, you need to omit the dose that day in the day of surgery. And if taken twice daily, omit the morning dose of that day, okay? So if it's taken once, omit, and if it's taken twice, omit just one dose and take the second one. And DPPIV inhibitors, you take as normal, doesn't really matter, you take as normal anyway, either the day of surgery or the day of the surgery. GLP analogs, you take as normal again, and SGLT, you take as normal day before surgery, and you omit on the day of surgery. If it's once daily or twice daily, doesn't really matter. And for insulins, you need to reduce his dose for 20% if it was Lantus or Levemir, and if it's twice daily, biphasic like Novamix or Humulin or whatsoever, there is no dose change before the surgery, and half the usual dose, morning dose of the patient, and leave the evening dose unchanged. Assume only one meal will be missed during the surgery. However, this is not always the case for most of the patients during surgery. And this happens with the elective cases, which we talked about. For emergency, stabilize and resuscitate your patients where needed. Consider whether antibiotics are needed or not for increased risk of infection, and consent to the patient and of the relatives, obviously. Special preparation. I mean, this is quite specific. We're not going to go through this. And thank you for watching, and wait for me in another video for PLAB and MSRA exams. Thank you very much.